Ian, do you want to
Yes,
comment on
thank
yours?
you, Dido. You've seen the written report. Obviously, this does cover some of the ground, again, that we discussed in the board in common, and so I shall take as read that we've had one opportunity to discuss at least some of the issues on here and just literally give a quick overview and then open it up for any questions. I think what's been evident to us for some period, certainly the last month or two, is really this year there are three major sets of issues going on that are going to take a lot of our time, the vast bulk of it, and they're all happening at the same time. Obviously, the first of those is a whole set of operational issues to do with the performance of the NHS, the preparations for the winter period that we know we will be entering into relatively shortly, the financial performance of the provider sector, and indeed as we work jointly with NHS England, the NHS group as a whole, and the issues of challenged providers, trusts going into quality special measures, which does occasionally happen, and clinical issues that need support from us. So there's a whole list of things under that category, and I'll say a little bit about that in a minute. The second issue is the opportunity that working with our colleagues in NHS England, we have to work with the NHS to produce the long-term plan. And that's a massive piece of work. We've discussed it extensively in the joint board meeting in common, and people around the table are very heavily engaged in that. And then the third element is the important process of joint working with our colleagues, again in NHS England, to create the aligned and coherent and supportive leadership that we can help the NHS with. And so there are those three things that effectively are all major and significant programmes of work. And I observe, and the report describes, that in some ways all of those are very significant at the moment and likely continue very significant definitions of our success this year. So they're all things that have to be done at the same time and can't be done in sequence. And there's a huge amount of activity going into all of them. You'll see the preparations for winter described there. I won't go into those in detail, but there's extensive winter preparation underway, extensive work underway to ensure that patients waiting for elective care, particularly those who waited for over 52 weeks, get treated properly. Extensive work on delivering a balanced position finance-wise for the NHS, and ongoing support to a number of trusts where that is necessary. So there's a huge amount of operational stuff. I'm happy to answer some questions, but it's probably enough there. Process on the long-term plan is well underway, and I think we discussed that in the board in common. It's a great opportunity at the inevitable time that we have to work this really quickly, though. So it's a huge process of engagement, a huge process of deliberation, and the next couple of months, I think, will be very important for the future platform for success of the NHS that we love. And thirdly, I think we are now making real progress, actually, and on the verge of making even more progress in terms of the joint working programme with our colleagues in NHS England. I'm particularly pleased that we are moving towards the point at which we go through the appointments process for the new NHS leadership team that Simon and I will be jointly privileged to run, and the appointments listed there include the corporate directors, including those like the CFO, the chief nurse and the chief medical officer that we will employ jointly, plus the posts that we will employ to improve the NHS, plus the critical 7 roles of the regional directors, and those are moving towards appointment as we speak. And so I think that process again will roll out over the next few weeks, and I think there's not a lot more to it in terms of joint working than that, but in terms of getting the leadership team intact, I think that will feel a big move forward. So I think that gives a very, very quick overview of the magnitude of the work that's being undertaken by the executives and others in this organisation, and increasingly demonstrates that pretty much the vast bulk of what we do is increasingly discharged jointly with our colleagues in NHS England. So I think that's probably enough of an overview, otherwise I'll start repeating myself, but happy if people have any questions that they want to pose.
Richard?
Because I just have one on Kings Lynn entering special measures. It's probably for a combination of you and Kathy, I guess. There's two questions. One is, to what extent will Kings Lynn on our radar as one of our places at risk? And Lisa, I was trying desperately to remember whether this is a re-entry.
It is a re-entry.
So
Kathy, do you want to talk to that? Because you've been really close to this one. But it is a trust that has gone on that journey again.
Yes, so happy to talk to that. So, yes, it was in special measures, but some time ago, so sort of prior to the current regime of special measures. But yes, it is a re-entry. In terms of was it on the radar, by the time it went into special measures, it had been on the challenge provider list for a few months. So there had been some indications of issues, and in particular in the maternity, but in a number of other areas. And I think there are broader questions for us to ask about these organisations that return in terms of their sustainability, and have we got to the root of the issues here? And I think that's something that we are thinking about. And of course it is in a patch where it's clear that there are other organisations in difficulty. Norfolk and Norwich is in special measures, as is the Mental Health Trust there, Norfolk and Suffolk. So it is a challenge patch, and we have as an executive team had some discussions about that. But this is quite a challenged trust now.
So it would be good to come back to one of these meetings about the sustainability of the measures that we take to get people out of special measures, and just, I mean, I guess these things will happen, but we just need to understand whether
why
people are getting out maybe too easily or too early.
Sorry, could I follow that? Because I was struck by the fact there are a number of challenged providers in that geography. I think I'm also right in saying that it's challenged from a commissioner side as well, if I remember correctly.
Yes.
So to what extent is, how do we think about that as sort of it's challenged at an organisation level, or do we think about it as challenged at a system level? And if it's the latter, what do we do?
Yeah, so I think there's both and, if you know what I mean.
Yeah.
So, and in fact, I was having some discussions yesterday about the fact that this needs to be looked at as effectively an STP, really, because you might say, on the one hand, the STP should be resolving, that should be part of their strategic approach. How do you make all of that stable? But actually, they're different issues for the different organisations. So the Norfolk and Norwich is a big organisation, teaching organisation, nice buildings, PFI and all the rest of it, should be able to get itself into good shape reasonably quickly, and I think that is our view and that of the CQC, in fairness. So that's a slightly different problem from the QE, which is a smaller organisation, and there have to be discussions really about how we ensure that it is changed sufficiently that this wouldn't happen again, and that the services are sustainable there in a high quality way. So I think that's a different one. And then of course the Mental Health Trust has got, again, different, but it's a very big patch that's covering, Norfolk and Suffolk, in fact. So I think overall there's some internal things, but then I think in terms of the wider, how do you provide the right level of healthcare to the population across that piece, really? And maybe it goes beyond that SDP, because there's some pretty good trust in James Paget not too far away.
I think we are developing our thinking in discussion with NHS England colleagues on some of this as well. So I think there, I could quote a patch on the south coast where both the CCG is, I think, in a financially challenged position, and the local acute trust is in a financially challenged position, and we and our colleagues have moved now to appoint a joint improvement director. Now clearly there's different issues when it's predominantly a finance issue than a quality issue, but I think there are these elements of the need for system improvement, because clearly on the finance side, particularly moving from a who owns the deficit debate to what do we do to improve things is clearly the obvious conversation.
Yeah, indeed. Ara, you wanted to come?
Yes, Chair. Ian's report makes a reference to the St George's.
Yes.
With the investigation, the appointment of Andrew Cash. Has that had any impact on the service provision in terms of access to patients in St George's, or it's the service continues despite the
You want
investigation?
to give us the latest?
Yes. So as you say, there have been some issues identified in the cardiac surgery unit at St George's. The system has come together to work carefully on that, and obviously number one priority is it safe? Are patients safe, and have they got access to their treatment? And I have now chaired with NHS England 2 quality summits, the last one being this Monday, including not just St George's but other provider partners, King's Health and Guy's and St Thomas's, all of whom have been very, very helpful in ensuring that patients are getting their treatment in a timely way. So the unit continues. There are extra safety things have been put in place, which I could go into considerable detail over, but just to be assured that they are in place, and the whole community, including the CQC, Health Education England and so on, have all been involved in overseeing that. So it is a challenging environment in terms of the fact that they are trying to resolve some issues, but it is moving forward, I think, and the panel that we have put in place with Sir Andrew chairing, so all the members of that are now broadly agreed, well they are all agreed, and that will be taking forward the oversight of all the reviews that are going on relating to this.
Thank you.
I just wonder if at some point we might look at structural matters in this. If you take King's Lynn, I mean, there's a similarity for a lot of smaller coastal hospitals, and if they keep coming back. I mean, whether it's Barrow, Whitehaven, you sort of see them and they sort of rotate, and then you start to look at other patterns, and you have to ask yourself why we face certain challenges in London particularly, and you draw a line north and south and you see certain patterns. I don't feel sufficiently cited on structural reasons as to why these things are, and I'd like to sort of separate what are structural failures as opposed to management shortcomings, shall we say, in that. At some point I wonder if we might just get some insight into that.
So very interesting that some colleagues within our organisation met with me earlier in the week to say, spotted exactly as you say, that there are a number of, and they were particularly focused on those sort of very rural, near the sea type places, to say, should we even do things like bring them together to learn from each other? How do they solve some of the problems and so on? So in that sort of space of what are the particular issues? Because there are some patterns that we are seeing, different in different, whether it's a metropolitan area or a rural, but the sea-bound rural areas seem to have a particular issue.
In our quest to live up to our name and to learn ourselves, I think it will be a very interesting piece of work to take either the metropolitan challenges or the rural coastal, do the piece of work and bring it to the board to challenge ourselves on what can we learn so that we systemically improve.
And I think that fits as part of the work of the new provider strategy directorate that I think we've committed to establish as part of our organisational changes, so that we can actually get under the skin of some of the structural issues that have been talked about, of which these are examples, I think, but there will be others. And that understanding is the first thing. Then the question is understanding what actions does one need to work with the NHS to take. But I think this is an opportunity for a more strategic review of some of these things.
Could I encourage us to do the coastal areas rather than the metropolitan? Because I think the metropolitan tend to get quite a lot of care and attention.
The coastal will be good.
Whereas, because I think we see exactly the same pattern in the commissioner landscape.
Okay.
Be good.
Elizabeth?
It's just worth mentioning that quite a lot of work has actually been done to date. So within the commissioner allocations, it is actually something called a sparsity adjustment. So quite a lot of good work has been done to date and there's evidence that we can use, which we can build upon. The key thing here is, though, when you've got such a big difference in the scaling factor in the tariff, most providers I speak to tell me they've got a structural issue. So we've got to make sure that there's no excuse, and well, we've got to very clearly be careful about what we define as structural.
Well, all the more reason for doing a deep dive
properly,
and getting us up to speed.
I think that we have to challenge the basic concept of a DGH and how small you can effectively, have a viable district general hospital. Because at the end of the day, a lot of these circumstances have got bog standard services that don't attract, unless you've got a nice portfolio of sexy services that attract fantastic clinicians. You're not going to appeal to the budding consultant who wants to make their mark, and I think that's a real issue. So if your turnover is less than 200 million or 250, you are really going to struggle. And I think we're setting up some of these organisations to fail. And if you look, if I pulled out a map of failing organisation 10 years ago, it ain't going to be that dissimilar to the ones we're faced with now. And what we're seeing, I think, is the concept of the DGH in these settings start to decay because they can't sustain a surgical take, a medical take, and obstetric services because they're just not built to the right scale. And that is a structural problem that has got no real solution to, because you become public enemy number one if you're going to close the obstetric unit or drop the surgical take. But I think they are legitimate issues and they will border on the safety stuff.
I'd just like to make sure we include workforce in this.
Yes,
definitely.
We saw it in Norfolk and Norwich the other day with the board to board, their people's turnover is low. Well, actually, their vacancy rate is high, whether that's for medical, nursing, or other professionals. So, I think it's important to include workforce in whatever review.
Completely agree.
Good.
That'd be good, actually.
Take it on.
Okay. Other comments on Ian's report?
Thank you.
Okay, excellent.